And then there were a couple questions around kind of a similar theme. Like, like what's most difficult about your job? What are the biggest issues, and how would you fix them? There are a couple along those lines.
Yeah, what's most difficult? About my current job now, or about my nurse, like when I was at the bedside? Current job? Doesn't matter.
Either.
Probably the difficult things that I do now is really dealing with a lot of different personalities. One of the things that we have to also publicly report are our patient satisfaction, or patient experience is another term you hear a lot. So they will get like a survey after you've been to the emergency room, and you know how surveys are. Usually you only fill them out if you're pissed. And so, people get upset because they want to know, why didn't you do the MRI right then and there? I don't understand. Well, it really wasn't called for. You had no symptoms to have an MRI. It was perfectly appropriate to send you with a prescription for an MRI to get it on another day. And so that's really hard to deal with. How do you kind of make everyone happy all the time? You really can't. And then, of course, you have all the different personalities of your doctors and your nurses, and and their ups and downs in their lives too. So kind of dealing with all the different personalities, keeping all the metrics, all the balls kind of up in the air that you need to keep up in the air. What fire are you putting out? It's never a good day when you look at your calendar and go, oh, I'm going to get so much work done today. Because something always, comes up and just sucks you into the vortex. And then probably the best part that I like is I still get the opportunity to take care of patients when it's busy. I can still jump out, and I like that. Yeah.
And then thinking about, I guess more generally, there were a couple people that asked, what your opinion is about, how can we fix our healthcare system?
Oh gosh. It's some days I think we just have to blow it up and start over, and then it's because it's like the billing. It's just such a mess. But other days I just really, I think what we have to do is be realistic. As you find injustices, you kind of have to get to the root of why the injustice occurred, and then try to get the laws to change. I mean, it's really the only way. Because we're so slow to change in healthcare in general. It's painful. But the hardest thing is going from an emergency room nurse to getting into quality or something. I'm like, well, what do you mean we can't just do this right now? I don't get it. Let's just do it. What are we waiting on? No, we have to have 7 meetings and all that. So we have to look at I think there's a lot of things. We have to get technology much, much more improved in healthcare. Because we have to be able to use the data that we find, that we have tons of data, especially now that we're getting to these electronic health records. There's so much available on everything. We have to be able to get that data, use it, and make really good decisions on it, but quickly, instead of having to have 17 meetings around it, and then who can get the data? Oh, I can't get the data out because the system doesn't work that way. And so I think we need a big focus on technology, innovation, and how can we, and not necessarily around the medicine, but around the business of healthcare. How can we streamline billing? How can we improve the electronic medical record? I do not believe that before I die, even if I die at 120, that we are going to have an electronic health record that is going to do what they said electronic health records were going to do. They don't talk to one another. People come in all the time, what do you mean? I went to my doctor, I told him all this stuff. You don't have that? Nope. But he's on your staff? Nope. And some places have it in bits and pieces. We're getting there. And the problem is it's not super glamorous. It's not Google, so it's not that cool. People aren't doing it, and it's not a whole lot of money in healthcare, so it's hard to get people that want to, write code for healthcare and make it better. And
Google sort of tried it and they couldn't figure it out.
Yeah, because it's brutal. I mean, I've launched 2 EHRs now, and it's really hard to get. Even with nurses and doctors and everybody involved, it's really hard to get everything to work. And part of the problem is we're still using old platforms and thinking we can make them what they are, and it's almost like we need to start over. We learned a lot in all of our years of working with electronic health records, and maybe now we should just start fresh. Yeah.
We're opening up to more questions. I have a couple other things, but
yeah.
So we're doing that group project.
Okay.
Kind of looking at this fake acne hospital that's in really bad places with patient care. And we're looking at 3 different types of kind of innovative care solutions. 12-bed hospital, the primary care team. I don't know if you've ever heard of either of those.
Yeah.
Have you ever worked with any of those kind of innovative solutions or looked at implementing those into the hospitals you work with?
So I have worked in some, like one of the big innovations that started coming out in hospitals was like pod nursing was one of the things, so that you'd have that like 10 or 12 patients, and you would have a CNA and you would have a nurse and you might have a secretary, depending on where you are. Really difficult in California because we have really tight nurse-to-patient ratios. So that really plays a factor into sort of your local things like that. But yeah, I have worked on that. Some of it works really well, and some of it, unfortunately, is too expensive to keep going. So I always say there's nothing that volume won't solve, and that is true to a certain extent. But if you have a smaller community hospital and you can't keep your inpatient volumes up, you can't staff. You can't have the secretary answering the phone for you because they can't afford it. You don't have enough people. It's like if you went to a restaurant and there was 3 patrons there. Are you going to have 2 waiters, a busboy, somebody answering the phone and greeting patients? No, you can't. You got to have like one guy running the whole thing. We got 3 people here. That's it. And that's kind of what happens with hospitals, is that you have these really great care models, but unless you have the volume and the payer mix, because remember, Medicare, Medicaid patients, they don't pay as well. And so if you have a really high or even like non-insured patient population, where do you cut costs? And unfortunately, just a huge amount of cost cutting at the bedside, because the plant still needs to run. We still need to have lights. I still have to report all those quality metrics on all those patients. So there's all these things that come into effect. There are great ideas. And for bigger hospitals, sometimes they work really well. Some of that pod kind of, the only thing about that is that can kind of sometimes lead to silos and one hand not knowing what the other's doing. So you have to remember to make sure you build in a lot of communication. One of the things that has happened every time when we launch an electronic health record is people forget to talk to one another. More times have we had patients go up to the medical floor instead of the telemetry floor, because the doctor forgot to tell the nurse. Because I put it in I put it in my orders. Yeah, but the plan all along was they were going to medical street. Then you came and saw the patient, put it in these crazy electronic orders that no one saw, and you didn't tell anybody. So that communication piece is the big thing you have to worry about when you put in a lot of technology too. Yeah.
I'm sorry.
Yeah. Did you have a follow-up, Nick?
Is communication a technology problem or a protocols problem? How do you
Yes.
solve that? That's a
Yeah.
huge problem.
It's huge. I think it's a little of everything. People get really wrapped up in the technology, and they think the technology. I have a tendency to do that too. Like even with it, we'll put it on the board, the tracking board. You'll see that patient ready for X-ray, or you could just tell me, But you kind of get into this, Cool. It's so cool. We have this new, we used to have literally had a year and a half ago this little whiteboard that we would write patient's name on, and then we had these little ambulance magnets that we'd stick on there for when an ambulance is coming. Well, now it's all electronic. I know it's gone. Oh, it's such a bummer. We had when the doctor went in to see them, we had a little check mark, so now the guys could go in and get insurance. And after we went live, first of all, we were so mired in the newness of it and so confused by where do I write that? You don't write it, you click. So it's just horrendous. That technology, that confusion around it, that shuts people's communication off, and then that sort of becomes their norm. And then it's definitely a style thing too. So, and a lot of times too, what people forget is when you would write out orders, you would write something on it like, give aspirin if not done in ER. Well, it was super clear. I could see that right on. Now in the electronic world, it's kind of hard to see that. And it doesn't translate well to the electronic medication administration record. And it's really harder to see. And that's where that communication piece is so important. So I would say that when you're writing your protocols and you're planning to go live with an electronic system, that's when you have to really emphasize with your staff and your physicians that this does not take the place of good old-fashioned communication. As a matter of fact, in the beginning, you should probably try to over-communicate everything, because I may not be able to see it in that nice, clean fashion I used to be able to see it in the paper world. Yeah,
Do you
Lauren.
find that communication is harder between like older generations or like newer generations coming in? Because there's probably more use of technology.
Yes, that's very true. It's interesting when you talk to somebody on the other end of the phone to give like report on a patient, let's say, and it's somebody that's really comfortable on the computer, and you go through your standard, this is Mrs. Smith, she's an 86-year-old female that came in with, and they're like, yeah, I saw that on the summary page, I'm good, like, skip. And the rest of us that learned how to do that report in a very regimented way so we wouldn't miss anything are like, what do you mean skip? Like, that's the way I didn't, like, they've already read everything. And they're sort of like, well, just tell me anything that I don't know. Like, her daughter's crazy, and, you know, get her a Diet Coke, she'll be happy. And, like, that's the information they want to know. The rest of it they've got right in front of them at their fingertips. While other people kind of want you to walk them through it, because they're not as comfortable looking through the record, and they'd much prefer that you kind of just told them. As a matter of fact, there's a lot of nurses, and we're really working hard, everybody does, they still write everything down on a piece of paper and then run over to the computer and put it in, because we used to call it our brain, because you'd get report on all your patients, you'd put a sticker there, and you write out your report, and that was your brain, and you carried it around, and all night long, you would kind of check off, because remember, there was one chart. And you couldn't get to it because the doctor had it or someone else had it or whatever, so you kind of group chart. When you actually got your hands on that paper chart, then you'd grab it and write all your stuff down, whereas now everybody can be in the same chart at the same time. So, but it's really a big change in, yeah, you don't have to wait till the end of your shift to put this information in. As a matter of fact, don't, because someone on the other end has access to that information then. So yeah, that's definitely generational. Even simple things like email, and I've had to teach a few of my nurses. I was like, no, we can use email, I promise. How do you forward this? Here, let me show you, because it doesn't, Outlook doesn't look the same as maybe their Gmail or whatever at home, and so they don't know how to use it, don't know how to put appointments on calendars and things, so definitely generational. Yeah?
Would you say that the inability to buy insurance, or at least process it across state lines, is an issue in terms of billing and stuff like that? It's not a terrible, we bill, and the thing about hospitals, we bill everybody, whether we get paid is a whole nother, thing. So we bill all day, and then we have people so a small percentage will just get paid right away. Then there'll be another percentage of people like that have a bizarre insurance that we're having trouble validating or whatever, there's a lot of behind the scenes. We do a lot of stuff up front now. Technology has allowed that, where I can put your stuff into all this software, and I know exactly what your copay is going to be. Of course, I can't do that till the doctor has seen you, which is sometimes also an area where patients get upset, because you go into a store, you know what you're going to pay for something, that the price is right on it. People say, well, I'm not that sick, and I don't really want to be seen until I know what the bill is going to be. So I kind of went off with your question there. I apologize for that, but that's yeah. So usually we do a lot of upfront. Like once you've been seen by the doctor, we can really pull and get into a lot of your records and see what you're going to owe. But again, just because we bill you doesn't mean insurance is paying. Yeah. Yeah, Anthony.
How do hospitals increase revenue? I've seen advertisements where they advertise their special services or something.
Yeah, good question. Yeah.
Because there are a lot of patients who are unsure, on Medicare or Medicaid, where the reimbursement is kind of low.
Yeah.
Do hospitals advertise more
We do. As a matter of fact, I have something I think a lot of people don't realize is I actually have a salesperson that works for my service line as well as several other service lines. And now that we have the ability to run a lot more data, we do target. We see people what in this age group, in this neighborhood, that's where we're going to send our flyers or whatever. That's where we're going to use Google AdSense and all that. We use all of that stuff, and we target specific people. We know that at the age of 40, you might be thinking about colonoscopy. So we're going to, so yeah, we do a lot of targeting. The other way that we increase revenue is by driving volumes, and we
drive volumes on things that actually make us money. So we want to get people there. So how do we get patients there? First of all, we stop and we say, well, what are we actually making money on? Because a lot of time now we're actually making money, and I say we in the general healthcare, on orthopedics. In the past, a lot of places didn't, because the prosthetic that you would put in, like the knee or the hip or whatever, was so expensive that you really weren't making any money, and we didn't want to do them. But now we make money on them because most hospitals have gotten involved in some larger buying, like a Costco for hospitals, basically, and we get these bulk discounts. And so we say, oh, we are making money on hip replacements, so now let's target that age group, and let's target those people that end up, and let's show happy people that supposedly had hip replacements, now they're golfing, and they're, so that we do a lot of marketing towards that. We run a lot of data on where do we make our money, what services, do we have those services? If we don't, do we want those services? OB is a huge moneymaker. And so what do? Everybody makes these beautiful birthing rooms with hardwood floors and lovely things to attract people. We hope that people will Yelp about their wonderful birthing experience. Like, we do all of these. Yeah, we do a lot of that kind of stuff. So what makes money, and then also part of it is getting physicians that will do it. So maybe we don't have the urologist that's going to do this fancy new procedure on the robot, which for many years robotic surgery actually lost us money, but we had to do it because the cool factor. Patients wanted it and expected it, so we kind of had to do it. Now we've figured out how to make money on that, and we want to use the robot more and more. And now there's a new robot, and you need the new robots. It's like, but yeah. So getting physicians in the door for the specialties that will make you money, and advertising to areas and people that will use those services.
So, quick follow-up question.
Yeah.
Isn't that drive up like healthcare costs?
Yeah.
Unnecessarily order procedures that make money, but
Yeah, so we never, I don't want to say never, but we don't want to order procedures that are unnecessary, but we definitely want to target those people that that would need that procedure, and then we want to entice them to come to our hospital. Yeah, so we really, the good news is that there's still doctors and nurses, at least involved in running hospitals to some extent, and we do have our ethics and morals, and we believe in taking good care of patients. Because you're right, it's possible that people could start ordering all kinds of unnecessary things. The insurance companies also keep us in check with that too, because they're going to say, really, this person didn't need that. We're not paying for that. Emily, you had a question?
Oh yeah. How's the kind of relationship and communication between administration and providers at your hospital? Like when administration tells providers to do something.
Right. Depends on who you ask. Administrators, we all think we're doing a great job, and then physicians and nurses will sometimes tell you that we're not. It really just depends. Again, it's kind of a personality thing. More and more physicians and nurses are getting it. They understand that usually administration isn't telling you to do something just because we wanted to. It's usually coming out of something significant. It's always been a big thing for me is to explain and give people the why. Like, so why am I asking you now that you have to give a justification for this central line to stay in the patient? Instead of just saying, just do it. You've got to do it. And if you explain to them, look, because we won't get paid for X, Y, and Z, and and here's what that equates to. That means we probably, if we never got paid on any of these things, we can't get that new robot next year. Like, sometimes you have to get down to the nitty gritty and tell them, like, we really want to be able to do this, but this is how much this is costing us when we don't do something as simple as checking that little box. So I think the important thing, I think we have pretty good communication where we are. I think we could always do better. I think the best success we have is when we give people the why and the reason behind why we have to do it. And unfortunately, sometimes that is like, well, just because CMS said we do. I don't have a good answer either, but we just got to do it anyway. So usually there's a good reason behind it. When they first started putting in OmniCells, which are like these big patient dispensing things, they're like vending machines for all of the patient equipment that we would use, the 2x2s and all that stuff, and it was because we could charge the individual patients for it. Nurses would go in and just take a bunch of stuff out on floor stock, or just take out like charge you for one item but take out 4 and then leave it at the bedside, and then, well, now it's dirty, I have to throw it away, I can't put it back in the machine. And we just started posting like how much that each of those items cost. Like every week we'd post a new one. And then we'd kind of say, this is approximately how many we go through if you were to take 2 out for every patient that only needed 1. And then equates to 1 whole nurse that we could have on this floor. So it's an extra set of hands. So when you kind of equate it, that really helps. Yeah.
Is there any difference with regards to how mental health emergencies are handled compared to, say, more physical injuries?
Yeah, very good question. Yes, there's a big difference. There's a real, state of California especially, there's a real lack of mental health services available. And so you come in, if you are gravely disabled or unable to make good decisions, and we worry that you could hurt yourself or something like that, we put you on what's called a 5150. In other words, we take away your right to leave because we think you're not safe to go. That's very different from any other patient that might come in and say, you know what, I don't feel like staying. Okay, well, we think you should because we give them all the reasons, but they can sign out against medical advice. But someone that we think is a danger to themselves or to others, we put them on, we have this ability to put them on this 5150 and hold them basically against their will. And then we start trying to find a psychiatric placement for them. And that can take a really long time because the facilities on the other end aren't really supposed to ask about insurance information, but they always find these sneaky ways to find out if the patient's insured or not. And then magically there's no beds. Well, we don't have any beds. Well, we have a bed, but it's our last it's our last bed and we've got to save one for, so something. So they'll sit, it's really scary how long. We're very blessed we don't get that many and we don't have them sit for very long, but it's not unusual for a psychiatric patient to sit in our ER for 12 hours, and that's not bad compared to other places. So I used to work, my last facility when I was bedside, we had a psychiatric emergency services that was a 3-bed unit that was sort of like next to the ER, like a couple doors down. Patients would stay in there for 3-4 days looking for placement. And it was just this little hole in the wall. It was really kind of sad. And they got care, but they didn't have group sessions. They didn't have their full complement of care. One of the cool things that we're actually melding technology is we actually have a new robot coming, which is really cool. I don't think you even know, April. So it's teleneurology. So for stroke patients, we'll have a neurologist on the other end within 2 minutes to evaluate the patient, but we can also use it for telepsychiatry. So for some patients, they'll be able to speak to a psychiatrist via this, basically like a fancy Skype kind of situation. And some of those patients maybe just need a med adjustment, a psychiatric evaluation, say, no, you're free to go. That will really change the way we handle psychiatric patients. But we do need more beds in this, really in the whole country, but especially California. We need more psychiatric beds.
Well, and the trend has been,
Yeah, the close on, yeah.
Well, I have a psychiatric.
Yes, and we closed it because we couldn't make any. Not only could we not make any money on it, we could barely. It was pulling us down.
Yeah.
It was just too expensive to run. Yeah, Nick.
The high revenue specialties like OP, do you ever have a problem with saturation in those areas? Do you in ER and other areas that are lower revenue?
We do get saturated. We're lucky that we have the ability to kind of overflow. It's right next to our med surge area, and we have the ability to overflow into that area. And because of the area that we are in, most of the patients that come to us, not that we know exactly who's going to come in the door, but we have their medical records already. They're being seen. A lot of areas that have an indigent population that doesn't have a physician or whatever, or is not getting prenatal care, they really have no idea who's walking through their door, when. They have no records on them or anything. So we have that we don't get we have a population that's doctored and, so they do get saturated.
So I guess more directly, the space available for a particular specialty,
Mm-hmm.
do you consider that to be as a result of the revenue production of the specialty?
Mm-hmm. Yeah, it makes money, we build more. We build nicer, we build more. Yeah.
So So I think, so maybe with one more minute, because it's one thing that hasn't, if you could just explain ambulance diversion, because it did come up in the film.
Oh, right.
Questions about what that is, just kind of explain what that is.
Yeah, so ambulance diversion is basically, it's different from county to county. Essentially, typically what it allows an emergency room to do is pick up the phone and call the 911 dispatch and say, we are inundated, we cannot take any more ambulances, and you can go on divert for like a specified period of time. In my last facility, we could pretty much go on divert and stay on divert like as long as we wanted. In Santa Clara County, I believe it's 90 minutes. So I think you get 2 90-minute reprieves a day. That's what it was in, oh my God, what county do I live in, April?
San Mateo.
Thank you. San Mateo County, I completely blanked. And then the county said, we're not allowing diversion anymore. So now we can't go on divert at all. Yeah, so it allows a stoppage of ambulance traffic, which can really kind of help you catch up. Doesn't stop the walk-in traffic. Yeah, cool. We have one more? Or?
Could I ask a follow-up to that?
Yeah.
How do you deal with an MCI?
You have contingency things in place. So basic
MCI is
mass casualty incident. Yeah. So like the plane crash at the airport, basically what happened is everybody we have this computer that's just dedicated to MCIs, and we get this ring, 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 and how many beds do you have? Because we have the potential to send you blank patients. So like a trauma center, the first thing they start doing is triaging patients out. You're not sick, you're not sick, you're not sick. Let's get this patient up to the floor. So you have all these policies and procedures in place to kind of move people. One of the things that a lot of the facilities in California and actually across the state, the country are using is this emergency department overcrowding scale. And it's this really long formula. You should look it up. It's some really smart person came up with this and figured it out. And it really matches to how busy you are, no matter what size your ER is, because you kind of plug a few constants in and then all these variables, and it kind of spits out a color. So green is fine, and yellow is like caution, you're getting a little busy. Orange is, whoa, we're getting a little more busy. Red is like, holy moly. And black is like kind of a disaster, an external disaster, an MCI. And that helps us a lot because we can put policies in place that say when it gets to this point, like orange, the floors, you better be ready to take your patients in 10 minutes. They can't lag down here for hours and hours, because then we're going to go to red next. And then if something like that happens, so you immediately start triaging patients out. They do it on the other end too. You triage, so like at the inpatient floors, we'll triage anybody out that doesn't need to be there. So maybe like, even like moms that have been there for one day and they could have a second stay, they're, scoot out, we have this big event. So we just kind of move everybody out. And then there's lots of alternative care areas that we can use. So in some areas of hospitals, like a conference room, you might not notice it, but there's actually like oxygen on the wall, and there's actually things maybe behind a picture or whatever that we can open up, and now we can treat patients there.
Did you guys go into that during the plane crash last year? Did you?
We enacted a little mini, but we had a feeling that with a plane crash, you kind of have two results. You're not getting anybody anywhere, or they're all going to a trauma center. And so we've got a few walk-ins, just kind of people that said they want to be checked out, but there's really not. But that had a whole other interesting thing because nobody spoke English. Yeah. So had our blue phones out all day trying to figure out, And they separated families, which was really scary. So, young people that, were not there even with their parents. They were just there with, I think on their class trip or whatever. They were kind of separated and didn't know where people were, and
Great.
Yeah.
All right.
Thank you very much.
Round of applause.